Hey everybody, this is Kevin Bass from thedietwars.com, and I'm going to be talking to you guys about homocysteine. In particular, the relationship between blood homocysteine levels and the risk of dementia, cognitive decline, brain atrophy, and even mental and psychiatric illness. To do that, I'm going to start by talking about this article called Homocysteine and Dementia, an International Consensus Statement. So it's a consensus statement of Alzheimer's and dementia experts on the role of homocysteine in the development of Alzheimer's and of dementia. And I'm just going to read through the abstract. After I'm done reading through this abstract, we're going to then dive into the deeper details of this story. But this is going to give us an overview. It says, identification of modifiable risk factors provides a crucial approach to the prevention of dementia. Nutritional or nutrient-dependent risk factors are especially important because dietary modifications or use of dietary supplements may lower the risk factor level. One such risk factor is a raised concentration of the biomarker plasma total homocysteine, which reflects the functional status of 3 B vitamins. A group of experts reviewed literature evidence from the past 20 years. We here present a consensus statement based on the Bradford Hill criteria and conclude that elevated plasma total homocysteine is a modifiable risk factor for the development of cognitive decline, dementia, and Alzheimer's disease in older persons. In a variety of clinical studies, the relative risk of dementia in elderly people from moderately raised homocysteine within the normal range ranges from 1.15 to 2.5. And the population attributable risk ranges from 4.3 to 31%. Intervention trials in elderly with cognitive impairment show that homocysteine lowering treatment with B vitamins markedly slows the rate of whole and regional brain atrophy and also slows cognitive decline. The findings are consistent with moderately raised plasma total homocysteine above 11 micromolar, which is common in the elderly, being one of the causes of age-related cognitive decline and dementia. Thus, the public health significance of raised total homocysteine in the elderly should not be underestimated, since it is an easy, inexpensive, and safe to treat with B vitamins. Further trials are needed to see whether B vitamin treatment will slow or prevent conversion to dementia in people at risk of cognitive decline or dementia. So this seems very clear that the consensus is that homocysteine levels within the normal range, above 11 micromolar, cause greater brain atrophy and cognitive decline in the elderly. This is a causal association. It's not merely something we see in the observational literature. It's not simply like looking at a population of people and then saying, okay, what is the homocysteine levels in this different people in this population, then looking either at that moment or say 5-10 years into the future, what is the rate of Alzheimer's disease of people at different levels of blood homocysteine? Oh, there's a correlation between the two. No, it's not like that. It's actually randomized controlled trial literature where they've taken people with elevated homocysteine levels, elderly people with elevated homocysteine levels, given them B vitamins or not given them anything, and then tracked the rate of atrophy in the brain and of cognitive function. And they found that people who have high homocysteine and are given these B vitamins to lower the homocysteine show a lower rate of brain atrophy. So literally, you can slow the rate of your brain atrophy by keeping homocysteine levels in the blood low. That said, it's important to talk about the details of the story because the devil is in the details. And so therefore, we're going to talk about both the nuances of the story, what are the blood levels of homocysteine that might be associated with a greater rate of cognitive decline, as well as some of the potential risks and applications of this bit of research. This is not medical advice. I'm not going to be telling anybody what they should be doing. However, I will tell you what the research says. The research suggests you should be doing if you're in different sorts of subgroups or subpopulations, and your risk factors are a certain way. And so I will be telling and reporting directly from the research evidence, interpreting it for you, and explaining what that means for you. Again, it's not medical advice, it's simply an interpretation of the medical research, which I think is a good interpretation. But with that out of the way, we're going to talk about first some of the studies that established the basis for some of these claims in this consensus statement in the Journal of Alzheimer's Disease. So first, we're going to talk about this paper called Homocysteine Lowering by B Vitamins Slows the Rate of Accelerated Brain Atrophy in Mild Cognitive Impairment, a randomized controlled trial. And it was published in PLOS One, September 8th, 2010 by Smith et al., David Smith in particular. And it says, an increased rate of brain atrophy is often observed in older subjects, in particular those who suffer from cognitive decline. Homocysteine is a risk factor for brain atrophy, cognitive impairment, and dementia. Plasma concentrations of homocysteine can be lowered by a dietary administration of B vitamins. And it says to determine whether the supplementation of B vitamins that lower levels of plasma total homocysteine can slow the rate of brain atrophy in subjects with mild cognitive impairment in a randomized controlled trial. That is the objective of this randomized controlled trial, also called VITACOG, VITACOG. And this was a randomized, single-center, double-blind controlled trial. So neither the doctors or rather the people administering the treatment and or the patients knew which group they were in. They were just given a group assignment and given a pill, which they weren't sure whether or not it was the intervention, that is to say the B6, folate, and B12 vitamin, or it was a placebo not containing any vitamins at all. Nobody knew their assignment. And so two groups of people received either a placebo with nothing, a fake pill, sugar pill, or they received this homocysteine lowering treatment of folate, B6, and B12. And everybody was over 70 years old with mild cognitive impairment, and a subset volunteered to have cranial MRI scans, so they had their brain scanned at the start and finish of the study. They were randomized to two groups of equal size, and this is 271 people. 168 completed the MRI section of the trial. The mean rate of brain atrophy per year was 0.76% in the treatment group and 1.08% in the placebo group. In other words, about, substantially lower, like 25% lower or 30% lower. The treatment responses are related to baseline homocysteine levels. The rate of atrophy in participants with homocysteine above 13 micromolar was 53% lower in the treatment group. So if you had a homocysteine level of more than 13 micromolar, your rate of cognitive decline was 53% if you had that treated, 53% lower. So you halved your rate of, not cognitive decline, brain atrophy. You halved your rate of brain atrophy if you had a level of homocysteine that was above 13 micromolar, compared to if you didn't have the treatment. So having your rate of brain atrophy, slowing it by half, sounds like a good deal to me. A greater rate of atrophy was associated with a lower final cognitive test score. There was no difference in serious adverse events in the treatment category. And so the conclusions and significance of this study are that the accelerated rate of brain atrophy in elderly with mild cognitive impairment can be slowed by treatment with homocysteine-lowering B vitamins, that is to say folate, B6, and B12. 16% of those over 70 years old have a mild cognitive impairment, and half of these develop Alzheimer's disease. Since accelerated brain atrophy is a characteristic of subjects with mild cognitive impairment who convert to Alzheimer's disease, trials are needed to see if the same treatment will delay the development of Alzheimer's disease. Overall, it's not conclusive for delaying the development of Alzheimer's disease, but it seems like pretty good to have your brain atrophy severely reduced. This reduction of brain atrophy is also associated with a reduction in cognitive impairment, cognitive test scores. And it seems like a good idea to do something like that. So there's a follow-up study to this, published not in 2010, but in 2013 in this case. It's the same, some of the same authors. It's called Preventing Alzheimer's Disease-Related Gray Matter Atrophy by B Vitamin Treatment. And the abstract reads, is it possible to prevent atrophy of key brain areas related to cognitive decline in Alzheimer's disease? One approach is to modify non-genetic risk factors, for example, by lowering elevated plasma homocysteine using B vitamins. In an initial randomized controlled study on elderly subjects with increased dementia risk, mild cognitive impairment according to the 2004 Peterson criteria, we showed that high-dose B vitamin treatment, that is to say folic acid at 0.8 milligrams, vitamin B6 at 20 milligrams, and vitamin B12 at 0.5 milligrams per day, slowed shrinkage of the whole brain volume over 2 years. Here we showed further by demonstrating that B vitamin treatment reduces by as much as 7-fold the cerebral atrophy in those gray matter regions specifically vulnerable to the Alzheimer's disease process, by as much as 7-fold, including the medial temporal lobe, which is associated with memory. I believe that's where the hippocampus is. In any case, it says, in the placebo group, higher homocysteine levels at baseline are associated with faster gray matter atrophy, but this deleterious effect is largely prevented by B vitamin treatment. So if you compare the high rate of brain atrophy in the placebo group in people who have a high homocysteine level with the people in the treatment group also with a high homocysteine level but then receive a treatment to lower their homocysteine level, those people who have their homocysteine levels lowered are going to have a lower rate of brain atrophy. This accelerator of brain atrophy that you see in those people with high homocysteine levels is essentially curtailed, drastically curtailed and prevented. So the effect of high homocysteine levels on brain atrophy is prevented by supplementation with these B vitamins. That's what the study's saying. And I'll continue reading. We additionally show that the beneficial effect of B vitamins is confined to participants with high homocysteine. So it's not just the B vitamins themselves, it's definitely the B vitamins acting on homocysteine levels in order to reduce the homocysteine levels and prevent the brain atrophy. And in this case, people are defined as having high homocysteine if they have above 11 micromolar homocysteine levels. And I continue reading. And that in these participants, a causal Bayesian network analysis indicates the following chain of events. B vitamins lower homocysteine, which leads to decrease in gray matter brain atrophy, thereby slowing cognitive decline. Our results show that B vitamin supplementation can slow the atrophy of specific brain regions that are a key component of the Alzheimer's disease process and that are associated with cognitive decline. Further B vitamin supplementation trials focusing on elderly subjects with high homocysteine levels are warranted to see if progression to dementia can be prevented. So I would like to comment further on this study before we dive even deeper. This study, again, just like the previous study that we saw, is done in elderly people. However, the question arises, since there's going to be a decline in brain matter over the entire course of the lifespan, different people have a different rate of decline, but everybody has a decline, a consistent year to year, maybe even month to month, maybe even week to week decline in the size of their brains, because the brain cells die and the brain shrinks over time. Would this homocysteine levels in the blood, would that actually affect brain atrophy over the course of the entire lifespan? And nobody knows. So there's been no studies investigating that. There's been no randomized controlled trials, long-term randomized controlled trials looking at the reduction of homocysteine levels in, say, people who are in their 30s or in their 40s. Does reduction of homocysteine levels in people who are in their 30s and 40s reduce the rate of brain atrophy, thereby helping to prevent people from actually ever becoming mildly cognitively impaired at all? We don't know. What we do know is that there's something called cognitive reserve, right? So since we're young, we have a lot of cognitive reserve, meaning we have a lot of gray matter. So if we lose some, it doesn't affect us too much. But as we get older and older, we lose more and more. And it gets to the point where we have a tipping point at which we start to lose function. It's possible that this reduction in gray matter isn't very well detectable in younger years simply because you have a lot of cognitive reserve and you don't actually result in functional impairment because you're not getting a great enough loss. Well, what if we simply stimmy that loss, reduce it in these earlier years so that we never even get to the point where we get anywhere close to needing to reduce our brain atrophy in later years so that we have an abundance of gray matter. So I suspect that if perhaps the brain, let me make another additional comment before we continue on that line of thought. Additionally, we also know that people who are older are more susceptible to all sorts of different things happening with their organ systems, simply because all sorts of cellular and organ level mechanisms to prevent bad things from happening are slightly compromised. So if the body, if you can think of a body as a series of different walls, a series of different barriers to prevent homeostasis from collapsing, and all these barriers have to be penetrated in order to cause the body to stop functioning properly. Well, as you get older, these walls thin, you lose some of the walls, so it becomes easier and easier for small events to perturb the homeostatic regulation of the body. So it's possible that simply having higher homocysteine as an elderly person is going to have a bigger effect on brain atrophy than it is as a younger person, because as a younger person we can compensate through other sorts of mechanisms easier. Be that as it may, it still may be the case, and I strongly suspect, leading to my conclusion, I strongly suspect that reducing homocysteine in the younger years, especially if done over a longer period of time, will also have similar brain beneficial effects as well. So I like this study because it really hints at, and we just don't know, we don't have enough evidence yet, but it hints at this idea that by reducing homocysteine levels and preventing them from getting high in earlier years, we could also prevent some of the risk of cognitive decline in later years. And of course, the rate of brain shrinkage as well. But of course, as I've said, this has only been done in the elderly so far, and we need the data for younger people. We desperately do. I think this is a great kind of study to do in younger people, and it's sad that it hasn't been done yet. But in any case, let's continue on to some of the other research to further clarify some of the points made in these two papers. So here's a really cool paper published in 2015. The first one was published in 2010, next one 2013, this one in 2015 in the American Journal of Clinical Nutrition. And it says, increased brain atrophy rates are common in older people with cognitive impairment, particularly in those who eventually convert to Alzheimer's disease. Plasma concentrations of omega-3 fatty acids and homocysteine are associated with the development of brain atrophy and dementia. And it says the objective, we investigated whether plasma omega-3 fatty acid concentrations, in particular eicosapentaenoic acid and docosahexaenoic acid, modify, that's EPA and DHA, by the way, modify the treatment effect of homocysteine-lowering B vitamins on brain atrophy rates in a placebo-controlled trial, VitaCog. This is an analysis of VitaCog. It's a retrospective analysis. And let's just get to the point. So the beneficial effect of B vitamin treatment on brain atrophy in those people who had high homocysteine levels was observed only in subjects with high plasma omega-3 fatty acids, suggesting that the beneficial effect of omega-3 fatty acids on brain atrophy may be confined to subjects with a good B vitamin status. The results highlight the importance of identifying subgroups likely to benefit in clinical trials. The idea being that in order for this homocysteine lowering treatment to work, you need high omega-3 fatty acids. So in addition to supplementing with these 3 B vitamins, which you'd also perhaps want to supplement with, although this needs to be tested in a randomized controlled trial, but this is the best data that we have, you also need to supplement it with fish oil, or if you're a vegan, algae oil. And one of the brands that can be used to supplement with algae oil is Ovega. So that's one brand, but there's many different algae oil brands. You guys look it up And if you guys have a really good brand that you like, leave it in the comments so that we can all share in that knowledge. But what we're looking for is a fish oil supplement or an algae oil supplement that will give us additional DHA and EPA. Probably DHA is going to be the more important one. And then take that on a regular basis, or eat fatty fish like sardines or salmon. Take those on a regular basis, along with our homocysteine lowering treatments to reduce the rate of brain atrophy and cognitive decline if we're elderly, and potentially to do so if we're also younger. Cool. So we're going to be moving on to some other evidence that suggests that homocysteine levels are also important in a number of other disorders. So in this case, they did a randomized multi-centered investigation of folate plus vitamin B12 supplementation in schizophrenia. And they found in 140 subjects that were randomized to receive daily folic acid plus vitamin B12 or placebo. They found that folate plus B12 supplementation can improve the negative symptoms of schizophrenia, which is to say like flat affect, like being emotionless, not wanting to speak, sort of. There's a paradigm of positive and negative symptoms of schizophrenia where the positive symptoms are like the stuff that you do too much. The negative symptoms are the stuff you're not doing enough. So you might withdraw socially, you might not talk enough, your expression might be flat. Those are negative symptoms. Positive symptoms are like, I have a delusion, I think I'm God, I think I'm being pursued by aliens that are trying to implant devices into my brain. Those are and then like I'm becoming like violent or something. Those are positive symptoms. So in this case, the reducing the homocysteine levels actually improved the negative symptoms, but the treatment response is influenced by genetic variation in folate absorption. These findings support a personalized medicine approach for the treatment of negative symptoms. In other words, you actually need to reduce your homocysteine levels, essentially. That's probably what this indicates. You need to reduce your actual homocysteine levels in order for the effect to work. And my suspicion is if they added B6 to the mix as well, they would further see a reduction in these negative symptoms, helping these patients. What this suggests is not only is this supplementation and this reduction of homocysteine helping out with the rate of brain atrophy, it's also helping out with the rate of mental illness. And these are probably connected somehow. If your brain is atrophying at a faster rate, you're probably not going to be doing as well, not just with respect to cognition, but also with respect to emotions and other sorts of regulatory processes that are important in proper brain functioning. So if you can, globally improve brain functioning, you're probably going to globally improve resilience to mental disturbances. That would be my guess. That would be my hypothesis about why it affects both the rate of brain atrophy as well as the rate of schizophrenia, severe mental illness. But we're going to continue on because we've got a bunch of other really interesting studies to talk about in this respect. So here's another clinical trial published in Biological Psychiatry called Homocysteine Reducing Strategies Improve Symptoms in Chronic Schizophrenia Patients with Hyperhomocysteine. And this one looked in particular at homocysteine levels. And in the background is an elevated homocysteine level is reported to be a risk factor for several diseases, including Alzheimer's disease and cerebrovascular disease. Recently, several studies have reported that homocysteine levels were elevated in many schizophrenic patients. Homocysteine levels can be lowered by oral folic acid, B12, and peroxidine, which is B6, another name for B6. And in the methods, it says 42 schizophrenic patients with hot plasma homocysteine levels above 15 micromolar. So the other two studies looked at 11 and 13 micromolar. This is above 15 micromolar, very high homocysteine levels. Were treated with these vitamins, again, B6, folic acid, and B12 for 3 months, and placebo for 3 months in a study were randomized with a randomized, double-blind, placebo-controlled crossover design. Homocysteine levels declined with vitamin therapy compared with placebo in all patients except for one non-compliant patient, difficult, quote unquote. We're not going to go further detail there, but some people don't like to take their vitamins. Clinical symptoms of schizophrenia as measured by the positive and negative syndrome scale declined significantly with active treatment compared to placebo. Neuropsychological tests results overall and Wisconsin card sort test results in particular were significantly better after treatment with vitamin than after placebo. And so it says a this conclusion is a subgroup of schizophrenic patients with hyperhomocysteinemia, that is a high homocysteine levels, might benefit from the addition of simple B vitamins. Okay, cool. That's like awesome. So again, we're linking schizophrenia with brain atrophy and cognitive decline. It's cool. So it sounds like a good idea to keep your brain from atrophying and keeping bad things to happen in your brain, such that you'd be more predisposed to having schizophrenic symptoms, and also worse neuropsychological test scores, which go quite beyond simply mental illness, but also just indicate overall functioning. Let's go to another study. This is a Mendelian randomization study, and you guys can learn more about what Mendelian randomization is, but it's essentially this idea that you look at different genes that are associated with different traits. So for example, genes that are associated with homocysteine levels in the blood. You know that they're associated with homocysteine levels in the blood because, well, there's a number of different ways by which you know this, but you know this fact, and you know roughly precisely by how much they're associated with homocysteine in the blood. And then you look at, who has these different genes and how much is their homocysteine supposed to be lowered genetically according to having these particular mutations or variants in this particular gene. And then you see, okay, so if this person has a, genetically predicted homocysteine levels that's 2 micromolar lower, do they also have a correspondingly lower rate of different outcomes? And in this particular case, they looked at bipolar 1, bipolar 2, bipolar in general, schizophrenia, major depressive disorder, and I believe that was it. Oh yeah, simply having a major psychiatric disorder in general. And they related that to their genetic score for homocysteine levels. And what they found is the results suggested that elevated plasma homocysteine levels may increase the risk of schizophrenia. Wow. So that's verifying and validating the randomized control trial in schizophrenia and bipolar 1 disorder. So it's a severe version of bipolar disorder, including both manic episodes and major depressive episodes. And he says, further randomized control trials are warranted to validate the Mendelian randomization findings in our study. And I want to read part of the discussion because it was interesting to me. And I think I believe it will be interesting to you guys as well. It says, our finding corroborates with many previous prospective observational studies that found high plasma homocysteine levels increase the risk of schizophrenia and bipolar disorder. Our findings draw attention to the potential mental health consequences of homocysteine dysfunction and provide more robust scientific evidence for future treatment guidelines. And they say this is the first study that has found such a thing. So again, not only schizophrenia, but potentially bipolar disorder. And it's interesting to speculate that maybe treating high homocysteinemia might actually improve the symptoms of bipolar disorder as well. It's a very interesting thing. So brain atrophy, schizophrenia, bipolar disorder, potentially. Actually, I don't even know if I've looked this up. Randomized controlled trial, bipolar disorder, homocysteine. Maybe there will be something. I can't find anything. So, can't find anything immediately, but if I do find something, I will report on it in a later video. Let's continue on. Okay, here is another interesting potential benefit of homocysteine. So, I didn't mention, but there was a period in time in cardiology in the 90s and in the 2000s where homocysteine, because of the observational evidence, was thought to be potentially important for the prevention of cardiovascular disease. So you wanted to keep homocysteine levels low in order to have low rates of cardiovascular disease. So based on these observational studies, and I talked about what observational studies were at the beginning of this particular video, but based on observational studies, they decided to do some randomized controlled trials, which is to say assign people to either placebo or an intervention to see what the outcome is over a certain period of time. To confirm that these observational studies were giving a real signal and weren't just confounded. We're talking about what confounding is in another video, but for the sake of this video, sometimes observational studies don't give the conclusion that you're expecting once you do the actual randomized control trial because there's particular flaws that are latent in observational studies that are not present in randomized controlled trials, and then you suss that out in randomized controlled trials and verify or disconfirm the hypothesis that was generated based on the observational studies. Okay, so that said, they did the randomized controlled trials in the 2000s, and in this particular case, they are doing another sub-analysis, a secondary analysis of, or I think we'd call it an exploratory analysis of the HOPE-2 trial, which is a homocysteine lowering therapy on the risk of cardiovascular disease. And what they found is that, I'm just going to read the abstract again, elevated total homocysteine is associated with a higher risk of cerebral vascular disease. It is not known whether lowering homocysteine impacts on stroke risk, both in terms of severity and ischemic versus hemorrhagic stroke subtypes. Our aim was to determine whether vitamin therapy reduces the risk of ischemic and hemorrhagic stroke as well as stroke-related disabilities. So this, again, an exploratory analysis of another study that looked at cardiovascular disease risk and the lowering of homocysteine. That study is actually negative. It didn't find any effect of homocysteine lowering on cardiovascular disease risk, but they're doing an exploratory analysis here to see, okay, well, maybe it found an effect on stroke risk. Let's look at stroke risk. That's what this study is about. And it says, we analyzed the stroke outcomes among participants of the Heart Outcomes Prevention Evaluation 2 trial that randomized more than 5,000 adults with known cardiovascular disease to a daily combination of 2.5 milligrams of folic acid, 50 milligrams of vitamin B6, and 1 milligram of B12, or matching placebo for 5 years. And what they essentially found is that you got a lower risk of stroke. So the incidence of stroke was about 25% lower. And the ultimate conclusions are that lowering of homocysteine with folic acid and B6 and B12 did reduce the risk of overall stroke, but not stroke severity or disability. So your strokes are going to be just as bad, but you're going to have fewer of them. Sounds like a pretty good deal to me. That said, we're going to go look at a few potential risks of lowering homocysteine in a moment. But before we do that, let's now emphasize we found effects of homocysteine on the rate of brain atrophy, on the rate of cognitive decline, on symptoms of schizophrenia, on bipolar disorder, potentially. It needs to be verified by a randomized controlled trial, but potentially bipolar disorder as well, now on stroke. So all of these brain-related outcomes perhaps related to the progressive loss of brain matter, and probably some other mechanisms as well that are not quite well understood. There's many different studies that suggest that homocysteine binds to different receptors in different parts of the brain. It might cause a cytotoxic response, that is to say a response to the cells that kills them. But it's not entirely clear why this is the case, especially like why you'd also have an increased risk of stroke in addition to brain matter loss. It's not quite clear why this would be the case, but it does seem to be the case that homocysteine in particular is particularly detrimental on brain function. But let's continue because we should talk about some risks now. So here's another study. This is called, what is this? We're just going to read it out. Homocysteine lowering in cardiovascular events after myocardial infarction. And this is published in the New England Journal of Medicine. Yes, it is the Norvit trial in 2006. It says the background, again, homocysteine is a risk factor for cardiovascular disease. Reevaluated the efficacy of homocysteine lowering treatment with B vitamins for secondary prevention in patients who had had acute myocardial infarction. And what they just did, which is a heart attack, and what they just did is they took more than 3,000 patients. They assigned them to either reducing their homocysteine levels with these B vitamins or not. And you had to have had a heart attack within the previous 7 days. So if you had a recent myocardial infarction, then we're going to go randomize you to this trial. And so they lowered homocysteine levels by 27%, but this treatment had no significant impact on the primary endpoint, which was cardiovascular events. Treatment with B6 was not associated with any benefit, and in the group given all 3 vitamins, there was a trend towards increased risk of cardiovascular events. It says treatment, but there wasn't a statistically significant increase, but it was a trend towards an increase in cardiovascular events. And it says the conclusion is treatment with B vitamins did not lower the risk of recurrent cardiovascular disease after acute myocardial infarction. A harmful effect from combined B vitamin treatment was suggested. Such treatment should therefore not be recommended. Okay, a few things before we comment further, and I want to go get into some general principles of scientific interpretation before we draw our final conclusions of the study, but it's an important digression because people get confused about this often. So again, observational studies can indicate one thing, but you have to actually test them by randomized controlled trial to know for sure. Observational studies often give us a false signal. And in this case, with homocysteine, it gave us a false signal with respect to cardiovascular disease. That said, this study is important, and we're going to go look at some of the things that it showed. I actually don't know the full details on this study. I know mostly the details on another study that's similar. We're gonna go look at the PDF. Okay, so there was a trend toward fewer strokes. There weren't a whole lot of stroke events, so it's unclear whether there are actually fewer strokes in the Norvit trial, because there simply weren't enough stroke events. But it's a trend, so about a 20% reduction in stroke risk, but a non-significant reduction in stroke risk. That said, it did show a borderline significant p-value of 0.05 of non-fatal myocardial infarction, which is concerning. It's quite concerning. So you might get a benefit from having reduced homocysteine levels in terms of your stroke risk, or in terms of your brain atrophy or bipolar disorder or schizophrenia, or all sorts of other brain-related outcomes that are important, but you might increase the risk of myocardial infarction. Now, this is somewhat speculative because the risk is borderline, but it's an interesting point. Now, let's confirm this, though, because if we go back to the HOPE-2 study and we look at the original publication, again, also in 2006, just like this one. Actually, they might have even been published in the same, I'm just curious, if they might have even been published in the same issue. Yeah, they're published in the same issue, these two trials, looking at homocysteine levels in a large-scale randomized controlled trial, published in the same issue, showing that in this case, this is, again, HOPE-2, we already saw that lower incidence of stroke. It says fewer patients assigned to the active treatment than to placebo had a stroke. So in this case, a reduction of about 25% strokes. However, more patients in the active treatment group were hospitalized for unstable angina, again, indicating a cardiovascular risk potential. And the final conclusion is supplements containing folic acid and vitamins B6 and B12 did not reduce the risk of major cardiovascular events in patients with vascular disease. But not put in the conclusions is this also important point that your heart outcomes might be substantially worse. Okay, so what's the take home here? If you're looking for brain health, reducing your levels of homocysteine is probably a good idea. Reducing anywhere from 15 to 13 to 11. So you probably want it substantially below 11 micromolar in order to fully optimize brain health. However, this improvement in brain health may come at the price of a detriment of heart health, which is very interesting and difficult to put together. But what we can say is this, and it sounds reasonable to me. This is an interpretation of the evidence, hasn't been fully tested, and it will take probably a while for this to get fully tested. So if you want to use these results now in your everyday life without knowing exactly where they're going to end up pointing, here's how you can do so. It seems to me that if you are interested in brain health and you have a low risk of cardiovascular disease, but say a high risk of Alzheimer's, dementia, or of cerebral vascular disease, or of cognitive decline, so you have a family history of it, it might be a good idea to reduce your homocysteine levels, since you're not going to be increasing a low risk of cardiovascular disease by much because it's already low. You're only going to be increasing the relative risk by a small amount, most likely, but then you can be substantially reducing your risk of cognitive decline and of adverse brain-related problems, potentially even schizophrenia and bipolar disorder and stroke, by reducing your homocysteine. If you are at high risk of heart disease but low risk of cognitive decline, it might be not such a good idea to reduce your homocysteine through the means of these vitamin supplementation. If you're at a low risk of both, it may not be the worst idea. I'm low risk of both. It may not be the worst idea to reduce your homocysteine levels. And this is what I'll be doing based on this research literature that I just recently discovered and I'm very excited about. It's probably a good idea to perhaps to reduce your homocysteine levels, because you're not going to be increasing your heart attack risk by much, and you're probably going to be improving your long-term brain health substantially. And we're going to talk more about heart disease risk in other videos. Suffice to say, if you want to maximize or optimize your heart disease risk, meaning you want to reduce it as much as possible, the three main things you could probably be doing is making sure your blood pressure is below 120/80, making sure your LDL cholesterol is low, and as low as like 50 milligrams per deciliter, making sure, of course, you exercise and you have good metabolic health in general. If you're relatively lean, you don't need to be obese, and then making sure you don't smoke. And those are going to be some of the ways you can optimize your cardiovascular disease risk and make it as low as possible. And if you do these things and then also lower your homocysteinemia, then you might be improving your brain health without much of any of a risk on cardiovascular disease. That would be my takeaway. If you have a high risk of cardiovascular disease but a low risk of brain atrophy or cognitive impairment, dementia, etc., it may not be the best idea to lower your homocysteine. But again, these are speculative ideas. These are the general directions that the literature is pointing me in. But these need to be tested more rigorously. But until we do that, we got to go with what we have. And this is what we have. And this is what I'm going to do. So let's talk about, and by the way, the things I just said are more conservative than some of the consensus statements released by some of the experts in the field. So some of the experts in the field in Alzheimer's disease are a little bit more aggressive about their homocysteine lowering recommendations than I am. I think that it's a good idea to lower homocysteine, but there are potential adverse effects of doing so. So you need to weigh the costs and the risks and the benefits of this particular approach. But given that, this is what I would suggest and recommend in general. No, this is what the literature suggests, and this is my interpretation of the literature. So take that as you will. In general, of course, your situation might also be very different, so please talk to your doctor and don't listen to me. I'm just a YouTuber. I'm just a YouTuber with a medical background and all that stuff, but still, nonetheless, just a YouTuber. So please take this stuff into consideration and talk to your doctor based on your individual, personal situation. Okay, so here's a really interesting paper by Richard Isaacson. He's at Cornell. He's at the Alzheimer's Prevention Center at Cornell. It's called The Clinical Practice of Risk Reduction for Alzheimer's Disease, a Precision Medicine Approach. He's got him and a bunch of other people on this paper. It's published in 2018 in Alzheimer's Dementia. It's the top Alzheimer's journal. And in it, I can't actually pull this up. Maybe I can pull this up on the screen. But anyway, I'm going to use this paper by this expert in the field to make, the recommendation about what the homocysteine supplementation regimen would look like. So he recommends folic acid, vitamin B12, and vitamin B6 for the reduction of homocysteine. So again, say about 11 or in his case, his definition is more than 10 micromolar. So if you've got more than 10 micromolar, you're going to use this regimen to reduce it substantially below 10 micromolar, thereby reducing your dementia risk. And he says brands that include, you're going to do a B complex vitamin, brands that include folic acid at 800 micrograms, vitamin B12 at 500 micrograms, and vitamin B6 at around 20 milligrams. But any range from 10 to 50 is reasonable each day. We do not suggest a specific brand and yet find the perfect combination pill. Most patients end up taking a B complex vitamin or 2 separate pills with the closest amounts they can find. So that's what you would want to do according to this renowned expert on Alzheimer's disease and dementia at Cornell. And until I dig deeper into this literature and am able to challenge that, if I ever decide I think I should challenge that at all, that would be what makes the most sense to me. I would listen to this guy. And of course, based on the same mechanisms, the same research that I've just presented to you, it's in his book as well. He tells the same story, but I just went a little bit more in depth so that you guys could get the best details on this particular topic. And though, remember to also take in conjunction with this your either fatty fish or fish oil or algae oil supplement that contains plenty of DHA and maybe even EPA as well. Probably focus on DHA, but having both on board would not be a bad idea. If you want to find out which is the best supplement to take for that, I'll talk about that in a future video whenever I cover omega-3 fatty acids. For our purposes, check out the latest brand, the best brand that you can find once you look at Dr. Google, but I'll give a specific recommendation of what brand I think is best in one of these upcoming videos over the next week or two. So pay attention to that video if you're interested in what recommendation might be a good one. With that said, I think that's a wrap. Again, I'm Kevin Bass from thedietwars.com. I'm a medical student and a PhD student, and I'm here to give you the latest details on a whole range of subjects, but in particular, this is going to be a video series relating to brain health and brain aging. And you can find me at thedietwars.com. You can also support me, support the work I've done, and help me out if I'm helping you out by going to thedietwars.com/support-me. You can also go to my Patreon at Patreon, of course, /KevinNBass, that's KevinNBass. For my Patreon, go to my Twitter, TikTok, Instagram at KevinNBass, KevinNBass, that's 2 N's, KevinNBass. Also check out my YouTube channel at KBass Philadelphia. Check out my podcast as well at The Kevin Bass Show on Apple and Spotify. Make sure to leave a review on Apple and Spotify, especially on Apple, where you can write up a review and get me higher and higher on the number of stars that I have, because I always have a bunch of people who are displeased that I debunk their favorite guru and write things and make like low stars. So if you can add a good review onto that, that would be fantastic, because that would be helpful for me to counterbalance that group of angry people who don't like that I say other people are not evidence-based. Okay, so yeah, that would be great. And again, just listen to the podcast, subscribe, click subscribe, and comment on this. If you have any questions, drop them in the comments section. If you have any comments, feedback, that would be great too, because I'm always interested in ways to improve things. I'm constantly making improvements, relentlessly making improvements, and having more feedback about what I'm doing not well, what I'm doing well is much appreciated because it will help me to continue to refine the process and develop as a podcaster / YouTuber over the coming months and years. And with that, it was great talking to you guys. Come back and watch the next videos on omega-3 fatty acids and brain health and a range of other issues with respect to brain health and brain aging in this series that I'm going to be making over the next couple of weeks / months. I hope you liked it. Have a good one. Peace.